Good evening to all. Today I will discuss a small experiment on mean arterial pressure and heart rate of the anesthetized dog. This is a part of the competency which students in pharmacology have to demonstrate the effect of drugs on the blood pressure as pressure responses and depressor responses and their blockage by appropriate blockers. This is a computer assisted learning or a simulation exercise, and I will start with a simple simulation. Now the program has been received from the Indian Pharmacological Society as early as 2004 as a free gift. A CD was received on dog blood pressure, which I have utilized for the software program. EP dog version E 1.1.0 is very simple to operate, and students can learn it by just pressing a few keys after demonstration. So it is very easy to operate by students also under simulated environment. Now this presentation is three parts. Part A is the demonstration of adrenaline, noradrenaline and isoprenaline effect on the mean arterial pressure and heart rate of the anesthetized dog, and second will be to demonstrate the vasomotor reversal phenomena as described by Sir Henry Halliday, and the third is how these changes are seen in the presence of beta blockers such as propranolol. So we begin with the first. Now these tracings have been taken by observing the effects of adrenaline, noradrenaline, isoprenaline, the carotid occlusion, the central cut end of the vagus stimulation, the peripheral cut end of the vagus stimulation, and you can see here that when the central cut end of the vagus is stimulated for 15 seconds, there is a rise in blood pressure and some rise in heart rate. This blood pressure is mean arterial pressure of anesthetized dog. Then carotid artery occlusion is done, and we see that there is a rise in blood pressure. When the peripheral cut end of the vagus is stimulated for 15 seconds, there is a fall in blood, there is a depressor response along with bradycardia. Now adrenaline is injected after saline injection, and we see a clear cut biphasic response in mean arterial pressure. Initially there is a rise and then there is a fall, and actually in appropriate setting this rise will be associated with small notch, which I will be showing you in the next slide. Now after the response of adrenaline is seen as biphasic response, noradrenaline effect is seen, which is seen as only rise in mean arterial pressure associated with fall in pulse rate or bradycardia. As compared to these two responses, isoprenaline causes rise in the pulse rate and fall in the mean arterial pressure. So isoprenaline only gives depressor response. Now there is an explanation for each of these. For adrenaline I will be discussing in detail, but today as we know, noradrenaline stimulates alpha receptors and also to some extent cardiac beta 1 receptors, so it raises blood pressure. Isoprenaline predominantly affects the vascular beta 2 receptors in this setting in anesthetized dog. So there is a fall in blood pressure due to vasodilation and decrease in perivascular resistance, and this is associated with some cardiac stimulation in the form of rise in pulse rate. Now the biphase of adrenaline is classically seen as drawn here. Initial phase of rise is because of cardiac stimulation and vascular alpha 1 receptor stimulation, and when the blood pressure is rising there is a notch is because of reflex vagal stimulation, but rise continues because of continuous vascular vasoconstriction and rise in the blood pressure. After some time, when maximum rise has occurred, then the action of adrenaline is dissipated by enzyme degradation in the tissues and neuronal uptake, and therefore it goes on falling. The response is declining. However, at low concentration, adrenaline is able to stimulate vascular beta 2 receptors, and therefore there is a fall in the blood pressure below normal. So adrenaline gives two type of responses: vasopressor followed by vasodepressor response. Now, if we treated this anesthetized dog with alpha blocker such as phentolamine, and let us see now how the effect of adrenaline and changes. So adrenaline at low doses of 2 microgram per kg gives biphasic response, and this biphasic response persists with 4 microgram per kg. Then we give phentolamine as alpha blocker, and in the presence phentolamine itself may cause some tachycardia and fall in blood pressure because it is alpha blocker. So it blocks the vasoconstrictor receptors of the blood vessels. So there is a fall in blood pressure because of fall in peripheral vascular resistance. However, more important, as is seen with asterix, the adrenaline response is converted from biphasic response to depressor response, and this conversion of biphasic or pressor response into depressor response is called as vasomotor reversal of Dale, as described by Sir Henry Hallett Darley as 1915. He actually demonstrated with ergot alkaloids which had alpha blocking action. However, now we know that almost all alpha blockers show this response. Example is phentolamine, cloxibenzamine, even prazosin also gives this response. In fact, these early experiments have paved way for development of autonomic drugs, and we also have understood that under physiological conditions there is a delicate balance in the autonomic control of the cardiovascular function, maintenance of blood pressure, and pharmacological manipulations can be done to achieve desired effects. Today we know we have alpha 1 blockers, we have beta 1 blockers, we have alpha 2 agonists, and all these have come up after these landmark developments by researchers and pharmacologists. Now in the part C, we will see the effect of adrenaline, noradrenaline, isoprenaline, and how this effect is changed with treatment of propranolol. As we know today, propranolol is a beta blocker. It itself causes a depressor response with bradycardia, which is explainable because of blockade of cardiac beta 1 receptors and blockade of the contraction, systolic contractions of the heart. When propranolol is followed by adrenaline, the biphasic response is converted into uniphasic pressure response only, but there is no depressor response. That means in the presence of beta blocker, adrenaline only shows alpha agonistic activity. And if you see the effect of the noradrenaline in the presence of propranolol, we see the pressure response is slightly increased, and this increase in pressure response is because unopposed alpha activity of the noradrenaline in the presence of beta blockade. Rightly, isoprenaline response is blocked because isoprenaline acts on beta 1 and beta 2, and both receptors are blocked by the. So these three changes which have occurred are: adrenaline does not show depressor response, noradrenaline shows greater pressure response, and isoprenaline fails to show any response. And this shows that propranolol blocks beta receptors, mediated vasodilatory response of adrenaline. In the presence of propranolol, alpha 1 vasoconstrictor response of noradrenaline is fully seen because it is unopposed by beta action, and isoprenaline stimulates beta 1 and beta 2 receptors which are blocked by the propranolol. So this is all about the basic understanding of the autonomic drugs on the mean arterial pressure and the heart rate of the anesthetized dog.